like, they are going to help you for both your MCQs in your university exams, more important case-based scenarios, questions that will be coming in your uh, university exam, and of course, definitely the NEET PG or INICET or whatever exam that we are going to, write subsequently. Right? Okay. Yes. So let me start. Let me just check if audio video is all fine and I can see everything is all fine. Okay. So let's start with question number 1. Guys, I hope all of you are able to hear me, and yeah, you can use the chat box to ask your doubts if you are having. Okay, question 1. Let us start with question 1. Okay, what does this say now? Let us look at this. Histological examination of liver biopsy in a patient suffering from, so this is a liver biopsy that has been given to us, in a patient suffering from cirrhosis is as follows, which is not likely associated with this disease. So question is, what is not likely associated? And this is the image given to us. What are we seeing in this image? Okay, image a little bit blurred out on my screen. Okay, what are you seeing? I'm seeing there is blue granules that you are seeing. I hope all of you are able to see these blue granules here. Yes, when I see such blue granules, what am I talking about? So blue granules, special stain done probably is Prussian blue stain. So this is your Prussian blue staining done here, right? Okay, so on a Prussian blue stain, and what am I saying? This is positive for iron, isn't it? So basically my diagnosis, what is my diagnosis here? I would like to offer a diagnosis here of what? Hemochromatosis. Hemochromatosis will present as, yes, hemochromatosis. Hemochromatosis will have cirrhosis, and that is what is there. Okay, which of the following is not associated? The question asked is which is not likely associated. Okay, it is not asking what is likely associated, it is asking what is not likely associated. Yes, sir. Tell me now, what are you thinking of which is not likely to be associated here? Yeah, not likely to be associated. Cardiomyopathy, yes, it is associated. Which cardiomyopathy is associated here? If you remember, DCMP, dilated cardiomyopathy is associated. Infertility, it is also associated. Why? Because there will be testicular atrophy happening, isn't it? Testicular atrophy happens in what do you call hemochromatosis. So that is why that is also associated. Next, malabsorption syndrome, it is also associated. Why malabsorption syndrome? Because pancreatitis will be there. So there will be pancreatic death or atrophy of pancreas. Both exocrine and endocrine pancreas will undergo atrophy. Both exocrine and endocrine are undergoing atrophy, and that is why there will be, yes, that is why there will be malabsorption also happening. Exocrine happens, malabsorption. Endocrine happens, type 1 diabetes, and option given to us is type 2 diabetes. This is a false, and that is the correct answer. It is not type 2. The association will be of type 1 diabetes. Yes, so association will be type 1 diabetes, right? That is the association here. There is a type 1 diabetes association in hemochromatosis, not a type 2, isn't it? Yeah. So this is not a type 2. That is wrong answer here. Type 2 is a wrong answer. Okay. Next question. Let us look at the next question now. Question next one. Okay. 34-year-old non-smoker presents with progressive shortness of breath in the past year. So he's having a respiratory problem, isn't it? Yeah. Examination shows mild icterus also. So there is respiratory problem and also what? Icterus is there. Okay. Then liver enzymes are elevated, of course. So that means there is some hepatic problem as well. Pass stained liver biopsy is as follows. So they have given a pass stained liver biopsy. Now, what are they asking us? Yes, what are they asking us? The question is which of the following? Yeah, question asked is which of the following is the mechanism? Which of the following is the mechanism of respiratory manifestation in this patient? So examiner is expecting you to make a diagnosis out of this, and once you make a diagnosis, then what? You need to be in a position to tell what is the mechanism of liver disease in this patient. Okay, let us look at now what is the question asked here to us. Okay, question asked here is, okay, there is a biopsy given, and these are very classical. What we are seeing here is pass positive globules are seen, isn't it? Yes, pass positive globules that are seen here. And such a pass positive globules, where do you see them? Pass positive globules are very characteristic of alpha 1 antitrypsin deficiency. That is my diagnosis, alpha 1 antitrypsin deficiency. And anybody, what will alpha 1 antitrypsin deficiency have? Alpha 1 antitrypsin deficiency will be associated with which respiratory illness? It will be associated with pan-acinar emphysema. Pan-acinar emphysema. And why is this pan-acinar emphysema happening? Alpha 1 antitrypsin, if you remember, so this is an integrated question between your hepatobiliary and the respiratory. Alpha 1 antitrypsin is required. It is an anti-elastase, and because there is a destruction of there is no alpha 1 antitrypsin secreted, there will be excessive destruction of alveolar wall. So answer to this question is option C. Option C, yes. Option C, very good, right? Yes, Jashwant, yes, you are absolutely right. This is an alpha 1 antitrypsin deficiency. Alpha 1 antitrypsin deficiency. Good, guys. Very good, very good. So this was alpha 1 antitrypsin deficiency. And what is the answer to this question? Destruction of alveolar wall. Destruction of alveolar wall is happening, isn't it? Alpha 1 antitrypsin is also associated with MPGN. Remember, membranoproliferative glomerulonephritis as well in kidney. Okay. Next question. Let us see the next question now. Okay. What is this question? 38-year female. Okay. Presenting with weight loss. Okay. There is weight loss. 38-year female and jaundice. Okay. Weight loss and jaundice. See, the moment you see weight loss, what do you think? Weight loss suggests there is a chronic inflammation. Remember, always when there is weight loss, it will suggest there is some chronic condition. So chronic inflammation or even malignancy also. I can suspect even malignancy, because malignancies are also chronic inflammatory condition. If you remember, cachexia is happening, right? Okay. She has no history of alcohol consumption. So important, negative history of alcohol consumption is there, or any hepatitis. Negative history of alcohol consumption nor any hepatitis. Serum AFP is normal. Anybody, why is examiner giving you all such history? AFP is normal, alpha what do you call it? No hepatitis, no alcohol. All these are in favor of what? HCC. Alcohol consumption is seen in HCCs. Yes, correct. Even hepatitis also can be causing, chronic hepatitis B and C can be causing HCC. Alpha 1 AFP also is elevated in HCCs, isn't it? Okay, so none of these are there in this. Imaging shows malignancy of liver. So tell me now, there is a malignancy of liver but not elevation of, okay, but malignancy of liver, is it common in 38 year? HCCs are usually common in young or elderly, we were talking. Yes, it will be more common in elderly, beyond 5th, 6th decade of life, not 38. 38 is too young for having HCC. Okay, so which was excised? So it was excised, and the gross examination is as given below. Anybody has made a diagnosis here? I want to see what is this. Now tell me, gross examination, what am I seeing in this? Look at this and please tell me what am I seeing in this here. Okay, so this is your normal liver. Okay, this is your normal liver parenchyma. Okay, and this is your tumor, isn't it? And in the tumor, what am I seeing? Look at this. This is a tumor in the center. Are you seeing a scar in the center here? Look at this. This whitish scar is there. So this is your, we call it a stellate scar is seen. A star-shaped scar, if you can carefully observe it. And star-shaped scar very characteristically seen in fibrolamellar HCC. Fibrolamellar HCCs. Okay, so my diagnosis would be a fibrolamellar HCC. My question, will fibrolamellar HCC occur in young or elderly patient? Answer is yes, it will occur in young, and also it will occur both in males and females, whereas normal HCC occurs only in males or very predominant in males. And important, AFP levels will be normal. There will be no history of alcoholism. There will be no history of any hepatitis associated with these. Okay, so answer is this is a fibrolamellar HCC. Prognosis is good prognosis or poor prognosis? Anybody? Please use the chat box and tell me good prognosis or poor prognosis fibrolamellar HCC. Yes, what about fibrolamellar HCC? Good or poor prognostic? It is a good prognostic, isn't it? Yes, fibrolamellar HCC, good prognostic. Okay, yes. Next, question number 4. What is this question now? Let us see this question. Okay, what am I saying? A patient underwent cholecystectomy. What is cholecystectomy? Removal of gallbladder. Okay, and gross examination is as below. Which of the following is a risk factor for this disease? So examiner is asking you which of the following is a risk factor. What am I seeing on gross examination? Can you tell me now? What are you seeing here? I definitely can see gallstones. Yes, correct. I am seeing gallstones here. But what type of gallstones I am seeing? Anybody? You are seeing pigmented or non-pigmented or cholesterol? These are pigmented because they are appearing dark and black. Pigmented gallstones. These are pigmented, not cholesterol. Cholesterol would be more yellowish in color, isn't it? So pigmented gallstones are seen. Which of the following is a risk factor? They are asking you. Obesity and rapid weight loss. No, this will be for cholesterol stones. Cholesterol stones. Hepatitis B is not a risk factor for gallstone. Sickle cell anemia, yes, is a risk factor because any hemolytic anemias will be risk factor for pigmented gallstone. Any hemolytic anemia, including your sickle cell anemia, is a risk factor for pigmented gallstone, isn't it? Female gender, no. Female genders again is a risk factor for cholesterol stone. It is a risk factor for cholesterol stone, isn't it? Yes. Okay. Yeah, very good. Any hemolytic anemia, if they had given, then also that would have been enough for me to make a diagnosis, right? So basically, answer is straightforward. You are supposed to diagnose pigmented gallstones, and that is what is the question here. Okay, next question. Question number 5. Question number 5. Liver biopsy from a patient suffering from chronic hepatitis shows ground glass appearance of hepatocytes. What is the likely diagnosis? So they have not given us an image. They might even give an image of ground glass hepatocyte image as well. But examiner here has not given us image. So tell me now, what is your... Yeah, it shows ground glass hepatocytes. Okay, guys, tell me now, what are you seeing? Where do you see ground glass hepatocyte? Very characteristically, it will be seen in chronic hepatitis B. Chronic HBV infection. So answer is option B. Option B is the correct answer here. Chronic hepatitis B. Right? Ground glass hepatocyte. Next, question number 6. Okay, what is this question now? Let us look at this question. Question number 6. Slightly tougher one. But yes, such questions do keep coming in INICET especially. Okay. Prostatic biopsy shows 60% well-formed glands, 35% glomeruli pattern and 5% cribriform pattern with comedonecrosis. Which of the following Gleason score of this patient? What is the Gleason score of this patient? If you remember Gleason score we discussed, there will be a primary score. Yes, there is a primary score and plus what? Secondary score. What is a primary and what is a secondary? Primary is most abundant pattern, isn't it? Most abundant pattern is primary and secondary is highest pattern. Highest pattern of the rest. So whatever rest is available, in that whatever is highest pattern amongst rest, that is your secondary. Amongst the rest, that is your secondary. So we have primary and we have secondary pattern, isn't it? Okay, so what are you seeing here? What is a primary pattern? Most abundant pattern is well-formed glands. Well-formed glands are pattern 3. So your primary score is 3. Primary score is 3. Next, secondary pattern, glomeruli is pattern 4, whereas cribriform with comedonecrosis is pattern 5. Now, so which should I be writing? Which is my second, whatever is the highest pattern amongst the rest is 5. So my score is 3 plus 5 is equal to 8. Option C. Answer is option C. That is the correct answer, isn't it? Yes. So this is 3 plus 5 is equal to 8. That is the score. And new Gleason's grade group. What will be the Gleason grade group? Gleason grade group, it will be 6 will be grade group 1. 7, 3 plus 4 is equal to 7 will be grade group 2. 4 plus 3, 7 is equal to 4 plus 3 equal to 7 is grade group 3, and this will be grade group 4. If you are asking me which grade group, answer is it will be grade group 4. Okay. Next, question number 7. Which of the following tumors of testis? So this is a one-liner question. Which of the following tumors of testis is not derived from? The word is not derived from GCNIS. Which is not derived from GCNIS? Yolk sac tumor, seminoma, teratoma, spermatocytic tumor. So in this, only one is best answer would be spermatocytic tumor. So spermatocytic, even if at all prepubertal yolk sac tumor will be not derived. Prepubertal YST is not derived, and even prepubertal teratoma also is not derived. Prepubertal teratomas are not derived from GCNIS. So things that are not derived from GCNIS. Which is derived from GCNIS here? Seminoma. Okay, now, so this confusion, okay. So be very careful. What is examiner asking you? Examiner is asking which is not derived from GCNIS here. So answer is spermatocytic tumor. Okay, next question. Let me look at the next question. 29-year-old man presents to clinic with painless swelling in his right testicle that he noticed about 3 weeks ago. So there is a painless swelling. He denies of any trauma, fever or urinary symptoms. And there is no history of undescended testis either. His father had a testicular cancer in 30s. Okay, that is one history given to us. AFP is normal. LDH is elevated. That would be the keyword now. Tell me, if LDH is elevated, what are you thinking? LDH is elevated. I am thinking of, yes, LDH is a marker for, we discussed, what is that? Seminoma. AFP is a marker for non-seminoma. So answer would be option seminoma. Yes, option would be a seminoma. Okay. Yes, that is the correct answer here. Seminoma. Okay, guys. Yes. Next, let us look at the next question as well then. So what is the next question? Let me look at this now. Question number 9. Okay. Gross examination of testicular tumor is as follows. Which of the following marker is not likely to be positive in this patient? Okay, so not likely to be positive. So word asked is not likely to be positive in this patient. So what am I seeing in this testicular tumor? Look at this testicular tumor. What I am seeing, this is a gray-white tumor. Yes, gray-white, it is the same. Okay, gray-white tumor, gray-white fleshy tumor without any. So there is no necrosis, and no gross much hemorrhage also. No necrosis is seen. So that is why my diagnosis would be what? This would be again a seminoma. This would be a seminoma. Okay, seminoma's cytokeratin is negative. Okay, so that will be the correct answer, by the way, because examiner is asking you which of the following marker will be. Yes, so that is the correct answer. Seminoma cytokeratin will be negative. CD117 will be positive. OCT3 will be positive. NANO will be positive. Cytokeratin is a marker for non-seminomatous tumor like embryonal carcinoma. Right? Yes. So this is your seminoma. Question number 10. One-liner question. Crystals of Rinke are seen in. Where do you see crystals of Rinke? Rinke's crystals, or crystalloids we call them, are seen typically in Leydig cell tumors. So if you remember from the class, I had shown you an image which had pink eosinophilic crystalloids within the cells, that is seen in a Leydig cell tumor. In granulosa cell tumor, you see Kohl-Exner bodies. Yes, you see Kohl-Exner bodies. Yolk sac tumor, you see is Schiller-Duell bodies. Spermatocytic, we see spermine chromatin. You see spermine chromatin in spermatocytic tumors, isn't it? Yeah. And lytic sedal tumor, that is what we discussed. What is that? We see ring case crystal. Ring case crystals are seen here. Okay, it's a fact oriented question. Okay, question number 11. Again, one more fact oriented. Which of the following is a mixed germ cell tumor and sex cord stromal tumor? Thecoma. No, thecoma is purely what? Sex cord stromal. Fibroma is also sex cord stromal tumor. Gonadoblastoma, correct. Choriocarcinoma is a germ cell tumor. Gonadoblastoma is the correct answer here, right? Gonadoblastoma. Next, question number 12. Histological examination of an ovarian tumor is as follows. Which marker is likely to be elevated in the serum? So, what is the question asked? Okay, histological examination has been shown. What we are seeing, look at this. In the center, you are seeing a blood vessel surrounded by tumor cells. There are tumor cells surrounded by an empty space. This is very characteristic. This is your what? Schiller-Duval body. Schiller-Duval body seen in yolk sac tumor or endodermal sinus tumor. And what is the marker for that? Option B, alpha fetoprotein. Alpha fetoprotein will be the marker for this Schiller-Duval or basically yolk sac tumor here, isn't it? Next, question number 13. Question 13, let me look at this question. 35-year lady presents with lesions in the vulva as shown in the image. Which of the following infection is most likely to cause this? Okay, so anybody, what are these lesions in the vulva that you are seeing here? Anybody has made a clinical diagnosis in this? Tell me now, what is this? Vulval lesions which are proliferating outside. Multiple, these are warts. Yes, these are your anogenital warts or genital warts, I can say. It is in the vulval region. Yes. What are these? Molluscum? No. Molluscum contagiosum? No. HPV6, HPV16, EBV is also not the answer. Which is the correct answer? HPV6. Why? Yeah, very good. 6 and also 11. 6 and 11 can be causing this. This is a low risk HPV. Low risk HPV. Yes, correct. This is a genital wart. Very good, right? Absolutely, you're right. These are genital warts, HPV6. But remember, if I get HPV 16 or 18 in this high risk HPV, that means these warts which are benign can progress to malignancy. Okay. Next. Question number 14. Question number 14. Which of the following is not true about use of pap smears? Which is not true about use of pap smears? Used for diagnosis of cervical carcinoma. Use has reduced the incidence of cervical carcinoma. Can detect precancerous lesions. Minimally invasive. Okay, minimally invasive is true. In fact, it's a non-invasive technique. We just put a brush and we take the cells from the cervix. Can detect precancerous lesion. Yes, correct. That is also true. Your LSIL and HSIL. LSIL and HSIL are precancerous lesion. That is also true. Use has reduced the incidence of cancer is also true. Why? Because we are detecting precancerous. Once you detect, treat them. If you treat them, then cancer incidence will decrease. Of course, why cancer incidence will decrease? Cancer incidence, new cases of cancer will decrease because you have treated them. You have treated them before the onset of cancer. So this is also true. Option A is false. Used for diagnosis, no. Pap smears or any cytological methods are not diagnostic. In fact, this we have studied this in neoplasia. In neoplasia, we studied none of your histological diagnosis or pathological diagnosis of cancer. We studied none of the cytological methods are diagnostic. So pap smears are not used to detect cancers primarily. They are used to detect precancerous lesions. They are used to detect precancerous lesions. Yes. I'm sure some of you have answered option B here, but B is true. B is true, A is false. Okay, yeah. So this is not used for diagnosis of cancer. It is used for screening of the precancerous lesion. Okay, yeah. Of course, it will help in diagnosis of cancers also, by the way, but it is not used for diagnosis of cancer. Okay, yeah. Next, question number 15. Okay, 35-year lady presents with severe abdominal pain. The pain is cyclical and coincides with menses. So she is having abdominal pain and it coincides with menses. Imaging shows a tubo-ovarian mass. Gross examination is as shown below. What is the likely diagnosis? Okay, serous cystadenoma, ruptured ectopic, endometriosis, endometrioid adenocarcinoma. So what is the answer? Very important is the pain is cyclical and coincides with menses. And plus, what am I seeing? Okay, gross diagnosis. What is my gross diagnosis here? My gross diagnosis, this is chocolate cyst. This is a chocolate cyst of ovary. I am seeing brown color. What is this? This is all hemosiderin, old hemorrhage. Very good. Chocolate cyst, that is nothing but option C, endometriosis. Very good. This is endometriosis. Right? Yes. Next, question number 16. Okay, let us look at this now. Slightly tougher question. 65-year lady presents with endometrial mass. Histology is as shown below. What is true about this condition? So examiner is not asking you diagnosis. What is true about this? This is a histology. Anybody made a diagnosis? Endometrial mass could be endometrial carcinoma. Okay, now I am suspecting what? Carcinoma in a 65-year. And what am I seeing? All these are papillae. So I am seeing papillary structures, isn't it? Okay, endometrial carcinoma, if you remember, there are two types of endometrial carcinomas, type 1 and type 2. Type 1 will have endometrium, proliferative endometrium like glands. Type 2 will have papillary or serous morphology. Very good. So papillary is there. That is why my diagnosis, this is a type 2 carcinoma, type 2 endometrial carcinoma. Type 2 endometrial carcinoma, isn't it? Estrogen is a risk factor. No, this is for type 1, which is also called endometrioid. Next, aggressive behavior than other type, that is true. That is a correct answer. Type 2 is more aggressive and poor prognostic. P10 mutation is seen, false. P10 mutation will be seen in type 1. P53 mutation will be seen in type 2. All of the above, of course, cannot be true. Answer is option B. So this is a type 2 endometrial carcinoma. Type 2 endometrial carcinoma. Next, question 17. Let us look at this question now. What is the question number 17? Yeah. 52-year postmenopausal woman presents with abnormal uterine bleeding for past 2 months. Okay, she is already postmenopausal, but still she is having what? Bleeding. Okay, and she has no significant medical history. On pelvic examination, left adnexal mass is palpated. So there is an adnexal mass or ovarian mass basically. Transvaginal ultrasound reveals a solid ovarian mass. Okay, so there is a ovarian tumor. And endometrial biopsy shows simple endometrial hyperplasia. So what all are given? So there is endometrial hyperplasia plus there is ovarian mass. So ovarian mass, and this is in postmenopausal as well. So tell me now, what is it? Because it is postmenopausal and endometrial hyperplasia, this ovarian mass should be estrogen secreting then. Yes. So why am I suspecting estrogen secreting? Then only it will end up causing what? Yes, this probably is estrogen secreting. That is why, which is leading to what? Endometrial hyperplasia. Otherwise, I'll not be able to explain endometrial hyperplasia here, isn't it? This probably is estrogen secreting. Which one? So now, what is it? A question asked. Ovarian tumor is likely to show endometrioid cells with atypia. No, endometrioid cells with atypia will be seen in endometrioid type of carcinoma. Very good. You might suspect a estrogen secreting tumor, that will be SCT, sex cord stromal tumor, and Kohl-Exner bodies are seen in granulosa cell tumor, isn't it? In granulosa cell. Schiller-Duell bodies are seen in yolk sac tumor. Trophoblast will be seen in choriocarcinoma. So answer is option B. Very good. Call exner bodies, because you are suspecting a sex cord stromal tumor here. Very good. You are suspecting a sex cord stromal tumor. Call exner bodies. Very good. So look at this question is twisted, little bit of understanding your ovarian tumor and endometrial hyperplasia, etc. Okay, question number 18, one-liner. This was previously asked in INICET, that's why I've given it here. Clear cell tumor of ovary is classified as fact-oriented, sex cord stromal tumor, surface epithelial tumor, germ cell tumor, mixed sex cord stromal tumor. Answer is a clear cell tumor of ovary will be also called mesonephroid tumor. Another name for this is mesonephroid tumor. Mesonephroid tumor, and this is classified as surface epithelial tumor. Surface epithelial tumor. So I gave you a list of so many surface epithelial tumor when we were talking in the ovarian tumor classification: serous tumor, mucinous tumor, endometrioid tumor, Brenner tumor, and clear cell tumors as well, isn't it? Yes. Next question 19. Fibroadenoma of breast arises from terminal duct lobular unit. No, from TDLU. It is the carcinoma of the breast arises from intralobular stroma. That is the correct answer. Option B. Interlobular stroma, no. And fat, of course not. Fibroadenoma is a stromal tumor which arises from intralobular stroma. Interlobular. So there will be a stromal proliferation which will lead to compression of the ducts, and if you will end up saying compressed ducts will be there, right? Yes, there are two types, pericanaliculaar pattern and canalicular. Anyway, so we have discussed those histology in the actual class, so if you refer to them you will get to know. And we discussed TDLU. So I told you that time also that examiner will ask you question what arises from where. From TDLU all your epithelial hyperplasia, duct hyperplasia, then DCIS, and all the carcinoma arises from TDLU. Then Paget's disease and papillomas are arising from the large ducts, isn't it? Yeah. And fat necrosis arises from fat, basically. Next, question number 20. Which of the following breast lesion has least malignant potential? Look at the question, which is having least malignant potential. Examiner is asking. If you remember, we divided the breast lesions into three types: without atypia, with atypia, and the least pre-malignant as well, isn't it? Yes, non-proliferative lesion, then proliferation without atypia, and proliferation with atypia, isn't it? Proliferation with atypia would be the maximum, highest pre-malignant, isn't it? Proliferation with atypia would be highest pre-malignant, right? Yeah, without atypia would be lesser pre-malignant, or non-proliferative, then proliferative with without atypia, then with atypia, isn't it? Okay. Radial scar. What is radial scar? Radial scar is nothing but it comes under what? So this is your proliferative lesion. This is proliferative lesion without atypia. This is proliferative lesion without atypia. Atypical duct hyperplasia is with atypia. Atypical lobular hyperplasia is also with atypia. Ductal carcinoma in situ is already carcinoma in situ. So in this case, answer is radial scar. Radial scar histologically includes three things. Anybody remembers what are those? Radial scar will have what? Ductal hyperplasia, DH I am writing short form. Then it will have sclerosing adenosis. Sclerosing adenosis. There will be ductal hyperplasia, sclerosing adenosis, and papilloma. It will be seen, all these three will be seen histologically in radial scar. And these are also called as complex sclerosing lesions. We call them complex sclerosing lesions. Histologically, we call them complex sclerosing lesion. This is both mimicker of, both clinical mimicker of carcinoma and histological mimicker for carcinoma of breast. Okay. Next, question number 21. Histological examination of breast tumor is as follows. What is the likely diagnosis? So what is the histology showing us? Look at this histology. What you are seeing, cells are arranged one behind another like this, and this is what we call single file pattern or an Indian file pattern. Indian file or single file. So they are arranged in single file. and this is very characteristically seen in lobular carcinoma. This will be very characteristically seen in lobular breast carcinoma. So look at this. These are all single file pattern. Yes, very good. Lobular carcinoma of breast. Lobular carcinoma of breast. Next, question number 22. Okay, another such question came previously in exam. HER2/neu analysis was done by IHC and classified as 0, 1 plus, 2 plus, 3 plus. Which of the following cases require FISH analysis for assessing amplification? So, HER2/neu done analysis on IHC 0, 1 plus, 2 plus and 3 plus. FISH analysis is required for which one? Answer option B, 2 plus. So, 0 and 1 plus on IHC are considered as negative. So, no treatment. 3 plus are considered as positive. So, treatment is required. 2 plus are considered equivocal. Equivocal, and these require FISH. So, these definitely require FISH for confirmation. These will require FISH for confirmation. Okay. Yes. So, answer here will be option 2 plus. We will do FISH in 2 plus cases. Next. Question number 23. Which of the following breast carcinoma is worst prognostic? Okay, which is worst prognostic? ER positive, PR positive, HER2 positive. This is your triple positive breast carcinoma. Anybody, what is triple positive breast carcinoma? ER positive, PR positive and HER2/neu positive. Triple positive. What will this be? Triple positive will be called as what? This is your luminal B. Luminal B. Luminal A would be ER positive, PR positive and HER2/neu negative. Next one, ER negative, PR negative, HER2 positive. This will be called HER2/neu enriched. HER2/neu enriched. This is your HER2/neu enriched. Then the third one, ER negative, PR negative, HER2 negative. This is your basal-like breast carcinoma, isn't it? Next, ER positive, PR negative, HER2 negative. So what is this? ER positive, then HER2 negative and PR is also negative. This will also be luminal B. This is also luminal B. So now what should be the answer? Yes, sir. What is the answer to this question? So which is the worst prognostic? Basal-like. That is the worst prognostic. Isn't it? Yeah, triple negative or basal-like will be the worst prognostic. Even if I did not know any other things, the fact is worst prognostic will be basal-like. Okay, question 24. Best prognostic histological type of breast carcinoma is, which is the best prognostic? Ductal, lobular. Ductal is the worst prognostic histological. Lobular is good. Medullary is also good. Lobular is good. Medullary is good. But the best, oh, basal-like is, so answer in this case, answer will be medullary. Out of them, medullary. But if tubular was given, tubular breast carcinoma would be the best prognostic if that was given. But that is not given. Basal-like, anyway, it is not a histological type. Basal-like will be worst prognostic. So in this, I will write medullary. Okay. Even lobular is good as compared to ductal. Even lobular is good as compared to ductal. Isn't it? Okay. Next. Let us look at this question now. What am I seeing in this question? Question number 25. The last one. Okay. Look at this. A 28-year-old health worker presents with fatigue, low-grade fever, mild jaundice. So he is a health worker, jaundice is there. Serology shows following: HBsAg is positive. Anybody? HBsAg positive. What does that indicate? Antigen is positive. So HBsAg, if it is positive, then definitely he is either having what? Okay, acute infection. It could be acute infection, or it could be a chronic infection, or it could even be carrier also. We do not know. HBeAg positive. Anybody? What does EAG suggest? EAG, if it is persisting, EAG is persisting. EAG is present. Okay. So that means infection is present. Okay. So definitely now I would say infection is present. For how long EAG is positive? If it is beyond 3 months, then we start suspecting chronic or even carrier also. Okay, that is not making us any difference. Okay, next, anti-HBC IgM positive. Okay, what is anti-HBC IgM positive? So very, very important. Anti-HBC IgM positive, this suggests it is a recent infection. It is a recent infection if it is IgM. And anti-HBS negative. So anti-HBS, what does anti-HBS tell us? Yes, anti-HBS is negative here. Okay. So anti-HBS usually it will be in what? Patient who are exposed to antigen, and it usually appears later. So what is the answer? Definitely there is a recent infection. Recent infection would be acute. So it is not a chronic hepatitis B. It is an acute hepatitis B. Very good. Acute hepatitis B here. Okay. Yes. So this is your, these were your questions from. So we discussed questions from hepatobiliary, then male genital, female genital, and breast as well. So I hope you got many of the questions right here. A few of them were tricky. If you are having any doubts, please put forward so I can take any doubts as well. And you can follow me in on Telegram. You can follow me Telegram. You can search at the rate path underscore logic. You can join this WhatsApp group, Telegram group, sorry. You can join this Telegram group, and where I'll be discussing a lot of MCQs, quiz, etc. So you can join that. Okay, guys. So I don't see any doubts here. Then I will be ending this session. Best wishes, all of you.